the wires and the bracket system that have been created by what you've done with Pitch 21 really helps solve a lot of those issues?
Oh, absolutely. Bracket position, the bracket, the protocols, and how I erupt the molars and intrude the lower incisors and extrude the upper anteriors. It's really exciting. So they're some of the most beautiful cases, which is hard to achieve with standard orthodontic protocols.
Hello there, everybody, and welcome to another episode of the Orthopreneurs podcast. Today, our two-time returning champion, you know him well, you love him, Dr. Tom Pitts. Welcome, Tom, and thank you so much for being here.
Oh, thank you, Glenn. Glad to be here.
For those of you out there who are following along, we were lucky enough to have Dr. Pitts in April. And just for the record, Tom, I have to tell you, calling you Tom is one of the hardest things I've ever had to do in my life. I have so much respect for you that Dr. Pitts is who you are to me, but I know you told me, no, you're Tom. So for everybody out there who's also wanting to call you Dr. Pitts, just know I'm not taking liberties, okay? I had the same hard time with my in-laws when they told me to call them Lenny and Sandy, and I was still calling them Mr. and Mrs. Schifrin. It's a respect thing. I'm sorry.
Oh, you're great.
I'm blessed to have you as a friend, and I treasure it. And I'm really looking forward to going through a few things here. For those of you who heard the first podcast, which I really would strongly recommend, we didn't get into a lot of clinical. We were talking a lot about, for lack of a better description, sort of the culture, the gestalt of orthodontics, a lot of the history of orthodontics as seen by Tom, talking about occlusion and our feelings about that. Today, we're going to talk a lot more about clinical. And it's not going to be a super long podcast, but we're certainly going to talk about a lot of the things that Dr. Pitts uses in his Pitch 21 system. He's really been generous enough of his time to put on a course that you'll hear more about down the road in September 6th, I think is the date, in Dallas, Discovering the Wow Factor in Orthodontics. He's going to do a one-day small format course. It won't have more than 50 to 60 people in it, I think. Here in Dallas, one day where you get a really good chance to get exposed to the kind of ideas and thoughts that he can share with us. And I want to talk about a number of them today. So first, since we've already gone through your story and your history and the other podcasts, let's jump right into it. I'd love to talk first because you said, discovering the wow factor is the title of the presentation in Dallas. What is a wow smile? What does the wow factor mean to you?
Well, the wow smile really has several characteristics, and it's been developing with me over the last 25 plus years. And one very important part of the wow smile is that we have full incisal display, including just a little bit of tissue if possible, so that makes a person look more beautiful and younger. The other thing is, of course, the smile arc, which is talked about a lot. And having that curve of the incisal edges of the upper teeth curving similar to the lower lip on a full smile. Of course, the shape of the arch also is very, very important. And the width of the molars and having lack of buccal corridors and that wide smile, but that arch form is very, very important. The other thing that's very, very important is to have the proper inclination of the upper incisors, cuspids, bicuspids, and molars. So they're and that way it'll bite properly and it looks more beautiful. So those are the main characteristics as you look at a smile. I see so many flared upper incisors. I mean, even a little flaring is not aesthetic, and it's not liked by the patient. And so that upright incisor is very, very important. And so as people try to do non-extraction of crowding and class threes and that sort of thing without the surgery, then it seems like invariably it's flared upper incisors. And so I've developed techniques, and it's particularly more easy to control that with the Pitts 21 appliance, that square appliance. And what we've been able to do with the wire we've got that torque control in the third wire. And so, which is a night-high wire.
When it comes to this, you talked a little bit about it. I just want to follow it up a hair. In what cases is it the hardest to get that sort of what we're calling the wow smile?
Oh,
Because
that's
I
right.
know there are cases that are tougher than others.
The more brachyfacial, the more shorter the lower face height, the harder it is to get that full incisal display. And they're particularly deep bites. So in correcting the deep bite and still extruding the upper incisors, that's tricky. And so I've developed some good techniques for that. And so that's the cases I see in so many orthodontic post-treatment cases, that they don't have full incisal display. And in fact, they don't even have half the incisor displaying, even though, of course, they can put a little smile arc in there and straight teeth, but this is far more than just straight teeth. And brachyfacial and even the mesofacial cases are challenging to get this type of smile, and that's what makes it so much fun. And the dolichofacial, of course, it's easy to get the smile, even though it's a little harder facially to get the result.
Yeah, those brachyfacial cases, I still remember in residency, like first year of residency, I had one faculty member say to me, deep class 2 bites, class 2 div 2 in brachyfacial individuals, he goes, you will earn your fee on those cases. He says, because they're just not easy.
Yeah.
You feel like the wires and the bracket system that have been created by what you've done with Pitch 21 really helps solve a lot of those issues?
Oh, absolutely. Bracket position, the bracket, the protocols, and how I erupt the molars and intrude the lower incisors and extrude the upper anteriors. It's really exciting. So they're some of the most beautiful cases, which is hard to achieve with standard orthodontic protocols.
And I think I can say for everybody listening, when you say the name Tom Pitts, you are beyond reproach when it comes to any sort of accusations or it's not the right word I'm looking for, but what I'll get to is everybody who went to ortho residency was told by some faculty member at least once or twice, the tooth doesn't know what bracket it has on it, right? You've probably heard that 1,000 times. And so that's why I started by saying, when I talk to Tom Pitts, this is a little different discussion than my, part-time faculty member in my ortho program, who I respect a great deal. But you're saying here, in essence, the bracket makes a difference along with the wire, along with the protocols, right? Would it be safe to say that the bracket and the wire, without the protocols, isn't going to give the kind of result that we're looking for? And someone would try it and say, why am I not getting, he told me if I use this bracket and this wire, I'm going to get what I want. The protocols have to be followed or you're not going to get there, correct?
Exactly, Glenn. Exactly. Bracket and wire, of course, are very important, but where you position the bracket, brackets on the teeth, as well as the protocols for the bite buttons and the immediate rubber bands, and it just all adds up. And that's why we've been able to take these cases, hard brachyfacial cases, and turn them around in a lot fewer visits. And but it's not just the brackets, it's not just the wires, it's a combination of the biomechanics plus that.
We've all learned bracket systems that people, some person comes into your ortho residency or came into your practice and said, this is the greatest bracket on earth. And you try it and you go, I'm still the same orthodontist I was when the other bracket. Things haven't changed a whole heck of a lot. I think an unfortunate part of our profession, and I'd love your feedback on this, is that orthodontists by nature, the ones I've met, are generally very smart people. They tend to be self-starters. They tend to be good learners. But there also seems to be this devaluation of the process, right? People that, you can go on any group, you could listen to Orthopreneurs taking any sort of clinical approach, and someone will say, who's done this before? What are the secrets, right? Along the lines of kind of like, teach me the whole Bible while I stand on one foot, right? I feel like people, they want to use a bracket and a wire, but they don't want to spend the time and the energy diving into the systems the way they should. And then when it doesn't work, they want to lambast the wire in the bracket when in fact, it's the protocols that they really need to learn. I have no doubt you've seen a ton of this, right?
Oh, yes, yes. And it's difficult. Most people treat the way they were taught in their residency, and they become accomplished at that, and then some, of course, go into teaching, and then but when they're teaching alongside of me, then there's conflict, because if I'm right, that makes their protocols out the window, and it's very difficult for them to do that. And I certainly understand that. It's not easy to have people change. That's why I created that master's course, is because it takes some time, because it's not really intuitive of some of the things I'm doing. It's like Einstein said, I think we discussed this before, you and I, but imagination is a lot more important than knowledge, because we all have knowledge like you're talking about. We all have gone through years and years and years of schooling and post-grad courses, and having that imagination. But then you can have that imagination, but then it's your ability to evaluate if that is really effective or not. And so that's what's been so fun for me. And like I said to a person last week, I said, I'm not in this because I want to be heard, because I want to give back to the profession. I'm doing it for the patients that deserve to have that extra wow in their appearance, in their smile, and that it's so important to their self-worth. And so that's why here I am in my mid-80s, kind of smashing my head against the wall, trying to help people. And fortunately, we've got a network now of several hundred people throughout the world. But I want to keep doing this, because I see so many post-treatment orthodontic cases that could have been so much better looking. And of course, the function is still important, and that's been tricky. That's why it's kind of anti-intuitive, because to do this with increasing the incisal display and setting up the arch like that, you'd think you have to create a deeper bite. So it's not only beautiful, but it's fun, and it puts more fun into orthodontics, I think.
Yeah,
that's why I'm still seeing patients.
I mean, I would make some trite comment like "God bless you" for that or what have you, but the truth is, you really are trying to make a difference in the orthodontic world. You're trying to motivate doctors to see things a different way, so that the patients that they're treating get treated better, right? It's about the doctor, but it's really about the patients.
That's the ultimate goal, is the patient. Yes. And I feel so bad when I see some of these post-treatment orthodontic cases, which I know could be much more aesthetic.
Yeah, but you were looking at my cases, and I apologize for that,
No, you're a good orthodontist. Plus, you have a great smile.
Oh, you've always said that to me, but I'm going to cover my mouth the rest of the time here.
I wish I had that smile.
Well, I appreciate it. You're very kind. When you talk about the things we talk about, and again, you and I, we could geek out for truly days talking about occlusion because of your background and my background in occlusion. And on the first podcast, I think we did a little bit of that. But when you're talking about a wow smile, when you're talking about the smile arc, when you're talking about what I was taught in school called a consonant smile, right? Something follows the lower lip really nicely. Overbite and overjet play a very functional role in the way we, chew, the way the whole, oral system functions. Overbite and overjet have a huge role. And I think, again, we won't go down the rabbit hole so much, but I'm curious, when you create the wow smile, and you've got your centrals, just like a denture setup, right? You start with your centrals, you work out to your laterals. It's the way I was always taught to do a denture setup with the front two teeth. place them in 3 dimensions in space, and then create your smile going back from there.
Right.
And right. And I suspect Roth probably was a lot like that as well, correct?
Well, I don't know that he started with the centrals, but I start with the centrals. That's how I treatment plan a case. So I start where I'm going to put my upper central, then my lower anteriors. And I know if I put my centrals up there at a certain point, I know where the lateral goes. I know where the cuspid goes. I know where the bicuspids go and the molars. So one thing you talked about, though, is the function and the occlusion. The thing is, I use intra-arch expansion with the wires, not from the palate, except for rare cases. And when you do that in orthodontics, it wants to flare the buccal segments, particularly with a rectangular appliance. So then you have to take the time and upright those if you're going to do this with the labial expansion. But the nice thing about the square wire in my square slot, it's actually not a square slot in the posterior, but it's 21 high all the way. So you put a 2020 in there, or even the 1919. As I expand, I'm getting torque lock up, and so I don't have to spend that extra time in uprighting those molars. So that saves me several months of treatment the way I do the expansion.
Yeah.
Ricketts is the one that taught me how to expand arch wires, and he didn't open a suture. He used the quad helix and that soft expansion. So he's the only one I saw at first when I got out of my university program that expanded arch wires. And so that arch form, the way I built my arch form, now I have a special wide arch form with the NiTi wires. So, but it gets exciting because you really see some quick movements, even though the pressure is less. The force from a square wire is less than a rectangular of the same composition.
So does that lead us into the next question, which, again, there are many doctors listening right now or watching who are saying, yeah, I mean, I do it that way too. That's the way you should be doing it. And there's many doctors out there who are probably listening and saying, if you're trying to do arch wire expansion this way, you're going to push the teeth right. You know, how many times have you heard that one? We're going to push the teeth right out of the cortical bone. So, like, here and now, how do you answer that question when a doctor comes up to you who's a naysayer? And I know there are many out there, and they say, you need to do skeletal expansion. You can't do this with arch wires. How do you respond to them?
Well, you just have to look at the cases. And you look at the cases and you can see, if you do CBCT, you can see you're not throwing the roots outside the bone. It's the alveolar process is very moldable, and particularly on the upper. And it even opens the airway on early treatment. That's done by Mike DeLuke, did that research with the CBCTs. And so anyway, it's just fun to, like I say, beat my head against the wall because I have a lot of resistance from the profession, and I understand it.
I'd like to see the person who's throwing stones at Tom Pitts. I want to be there for that one. Because again, it's not just who you are as a teacher. It's not just because of the innovations you've created, but you've done this for a while. For those folks out there who, I know you and I are not the same age, but for those out there who don't have enough white in their hair, right, throughout their, it's starting to creep up now to the temples, and soon it's going to be over the whole top. But the white hair are lessons you've learned along the way. And you've had a chance. I remember Morty Amsterdam, and I may have mentioned this in our first podcast, the late, great, venerated Morty Amsterdam, who really is the father of modern perio-pros out of Penn. I was fortunate enough to be in a lecture of his where he showed 50-year cases, 50 years, cases that he had done, 50 years earlier. He had slides back in the slide. He had slides on cases for 50 years. And so anybody who wants to throw stones at Morty Amsterdam had better have cases that they followed for 20, 30, 40, 50 years, because he did. And I have no doubt that the data you're presenting here comes from experience of following cases over a long period of time, correct?
Many, many others be treating this way. And so we have a lot of cases, a lot of cases.
Again, I could talk to you for days because you're such a wealth of information. But you did say that the system that you're describing helps with airway. You said Mike DeLuke did the study on it with CBCT, helps with airway in, early intervention with, I assume, pediatric population. But even that, even the idea of airway and ortho, just in Orthopreneurs yesterday, someone posted something about, and that stuff, which is airway, which is so not even science based, which, by the way, newsflash, if you've trained with the Stanford team that I have and like many have, you'll see all the science behind it in legitimate medical journals. But how do you respond, Tom, with your experience, to somebody who goes, this whole thing with airway is just a bunch of garbage. We're not influencing airway in any way. We're orthodontists. It's shameful that we're even talking about this. I'll give them my talk, but I'd love to hear what you would say to somebody who says there's no way it's not playing a role in airway.
It's living in the dark ages if you don't realize how much of effect we have on the airway, both with mandibular propulsion as well as expanding the arches. It's just obvious. Of course, you have to deal with adenoids and tonsils, but I mean, we have a great effect on airway. And if you don't believe it, I mean, there's so many courses on that now, and so many people doing research. I can't imagine that you're not involved in the airway help that we do. I mean, gosh sakes, that's big time. I see so many extraction cases that really have apneic problems, especially if they're brachyfacial or mesofacial. Dolichofacial don't seem to have as much of that issue, but that's a big deal.
Yeah. The reason I think that this has happened, I think, first of all, there's that, the bell-shaped curve, the adoption technology curve, right? There's always the people who are the pioneers, there's early adopters, and then at the other end of the spectrum, there are the laggards and the people like it's like that with everything, right? And when you develop a new bracket system, people are going to say this is garbage, right? And the people, no matter what you show them or what you teach them, they're going to say it's garbage, and that's just the nature of humanity. But I do think in the world of airway, I think what's happened here, and it's really a shame, is there have been some individuals who are not science-based, who have, particularly outside of the orthodontic profession, who are general dentists, who have pushed an agenda to make a lot of money on the backs of these families. And I think that's rubbed a lot of people the wrong way. There's a couple of general dentists I can think of top of my head who are strong advocates for airway, who, when I listen to what they say, it is not science-based. It is not. And I think the old adage, throwing the baby out with the bathwater, I think that's going on here. That people equate an orthodontist. I don't know anything about airway. I've never taken a course. I don't know anything about it, but I see these people talking and they're spouting garbage. This whole thing has to be garbage. And the reality of it is, if you look at the literature and you look at the science, and most importantly, like everything else, if you get trained, if you go and learn from people who know what they're doing, airway isn't garbage. In no way, shape, or form. There's legitimate science behind it. And again, it was great hearing you say that, because I think there's such an opportunity in our practices to conservatively change the lives of so many parents and children. If we can just, at the very least, be a gatekeeper. Say you don't want to get involved in treatment, fine. But at least being a gatekeeper for these kids who are facing these problems, I think, is a big deal. And I'd be curious to know, when was the first time, year-wise or in practice, that you first identified the role of airway in orthodontics?
1974.
74?
Course. Yeah.
Which course? I'm sorry.
He was into airway. And
who was it? I stepped on you. I apologize.
Robert Ricketts.
Wow. I didn't know that.
This whole evidence-based argument is rather silly. I put orthodontists into two categories. One is the orthodontist that's into excellence first and money second. and the other is money first and excellence. Whatever I can do, the quickest way I can do it. So, I mean, if you're really open to excellence, then you've got to study the airway, and the research that is going on. I have a neat orthodontist that's married to a physician up in Idaho. That's they're doing a lot of work on airway, and but it's just a matter of, are you going to get out and study that, because it can make such a difference. I mean, even bedwetting and everything else. I mean, they've done so much research on this plan. So I don't know if I'm waltzing around the
No,
topic here, but
no, it was great. It was great. And I'm just thrilled to be able to spend time with you, Tom. Again, thrilled to call you a friend. I'm beyond ecstatic over the fact that, number one, you're giving that course in my neck of the woods here in Dallas for Orthopreneurs University on September 6th. It's not available to, maybe available to register for. I don't have a link as of right now. But more importantly, I'm excited to have you next year in Vegas, right? I haven't even announced the Orthopreneurs Summit yet to anybody, but you've been gracious enough to say that you'll be on the stage at Orthopreneurs Summit next year in Las Vegas. And I decided 2025 is the first year that Orthopreneurs Summit will be both management and clinical. And you're among probably a half a dozen people who I look up to in the world of ortho as giants. And I'm just thrilled that next year to be able to have you on stage talking about the clinical and management in ortho is going to be, it's going to be one of the highlights for me of Summit ever. So thank you for agreeing to do that.
well, it's certainly a pleasure for me. I know this is not a mutual admiration society, but since I've gotten to know you, you're really a giver for our profession. And I can appreciate that so much. You had so many years of experience as a general dentist and restorative dentist. And that just makes you such a good evaluator of all of these things that you talk about. And you do the podcasts and you do your training courses. And in fact, I'm excited about going on your cruise. I'm just however I can be around Glenn Krieger right now is really important to me.
All I know is there's going to be a Hawaiian shirt sighting. I know that. There's going to be a Tom Pitts Hawaiian shirt sighting without a doubt. But thank you for the kind words. It really means the world to me. And before I let you go, I just want to give you an opportunity to tell everybody, we talked about the one-day course in Dallas, which I think is a remarkable way for anybody to learn how to become more efficient and to dive a little bit into the systems that you teach in your bigger course, your mastery course, which is a 2-year program, 4 meetings, 3 days, 3 to 4 days per meeting it's really a mastership. Do you want to take a minute or two and just talk about that real quick so that anybody can learn more about it if they want to take it?
I originally developed it when I was working with Ormco, and because it was so difficult to finish for most of us with that Damon self-ligating bracket, I wanted to show people how that I've worked around certain things. And once I started getting into it, it's just so hard for people to realize from a one-day lecture exactly how I'm doing it. So that's why I developed that 4-session, and each session is 3 to 4 days. And we've got so many people that talk so greatly about it. But anyway, that's we start next March. I think it's March 25 that we start out. And I'm going to give a one-day course August 16th in Denver. And but I'm excited to come to Dallas. I think that's going to be a fun group because you attract people that I think are really into excellence. And so I hope I can live up to my end of it, Glenn.
I'm not worried about you. I appreciate it. And I'm looking forward to people being a part of it. And again, it'll be part of the Orthopreneurs University course selection. So if anybody wants to know how to get there, if there's not a link associated with this podcast, reach out to me and I'll connect you personally to the website. Tom, it's always a pleasure. I can't thank you enough for being a part of this today and for all you do for our profession and for our patients. And again, just want to say thank you for being here today.
Thank you, Glenn. I really appreciate you.